HealthIMPACT. We are here today with Ron McKee. He is the System Administrative Officer at MUSC Health. And we met back in 2019 in person in New York at the Digital Medicine Conference. It was actually the last in-person event we did before the pandemic happened. So it's great to see you, Ron. Thanks for being here today.
Good to see you.
So it's been a long few years there, right? It's been, a long 3 years. Tell me what you've been up to. Tell me about how your roles changed. I think you were over at Hopkins then, so you've had a move and a new role. So tell me about that.
Sure. So I actually came right in the heart of the pandemic, perfect time to make a transition to the Medical University of South Carolina to do a system administrative officer role over imaging services. So MUSC owns 14 hospitals. They were trying to integrate across the health system. So it was really a good opportunity for me, creative opportunity for me, and to really get back to my roots, which is being back down south where I belong. So Hopkins was an amazing place, but a little too cold for me.
Yeah, I bet that's nice. And then I know you have a new role coming up. You want to tell us a little bit about that?
Sure. So I'll be transitioning into our Columbia market, which is 3 different hospitals in the capital of state, South Carolina. We have 3 hospitals there that we just merged with about a year ago that are in transition, and they're looking for a new chief operating officer. So I'll be taking a COO role of that market probably over the next 30 days, making that transition. But if we're going to be honest, it'll probably be a 6-month transition. So multiple feet and multiple different pots right now. So it's a lot of work, but it's fun. Opportunity.
That's exciting. Congratulations.
Thanks.
And do you still do clinical work at all, or completely administrative, in the operations side?
Yeah, I've been probably completely operations now for about 15 years. So I made the transition. Obviously, the height of COVID, we all did what we needed to do and, got into the weeds and really helped out. Put on some gloves and moved patients and did what we need to do when we were short staffed. But for the most part, I sit in an office and do meetings and planning and budgets and more purely administration.
Right. And now with the, I know you had mentioned that MUSC had done, they've done a lot of expansion over the last couple of years. Tell us a little bit about how that's impacted your role and internally. I mean, with the pandemic and with, obviously we're in the midst of the, great resignation that is impacting healthcare, in numerous ways. Tell us a little bit about how that's been and how the integration has helped and what the things you've been working on.
Sure. So to be honest with you, in the last 3 years, we were, I came on board when we had just bought MUSC Florence, MUSC Lancaster, Marion, and Chester, 4 hospitals kind of in the upstate of South Carolina. Mm-hmm. They already had transition plans to purchase the 3 hospitals in Columbia and 4 hospitals in our like Murrells Inlet, Myrtle Beach area. So that all happened since I've been here. So it moved into that transition. And I think just like every great organization, they're trying to expand to improve their footprint to take care of their patients. So we pretty much cover the entire state, and we're getting ready to make another transaction here soon that will help us with that. I will say that COVID kind of put a huge damper on a lot of our growth. We have bought a lot of hospitals, but we're trying to staff 14 hospitals and compete against ourselves and compete against other hospitals in our markets for staffing. And in full transparency, I think it's probably been, in my 26 years, it's probably been the hardest I've ever had to recruit and to bring in staff. I actually gave a lecture on this not long ago in Barcelona, Spain, talking about a problem that we're having with staffing. And I was on stage with somebody from Ireland, Germany, Great Britain, and obviously the US. And we are all talking about the same problem. So it's not a South Carolina problem. It's not a North Carolina problem. It's not a US problem. It's a nationwide problem. Mm-hmm. And really what happened is, I think most of us know, especially in the US, we had the baby boomers that really were a big part of our workforce. And those folks were getting ready to transition over a 10-year time, which is fine because you have an influx of students coming in, right? So the students are a pipeline in, we got the baby boomers going out, it's spread over 10 years, we can make it work. Mm-hmm. COVID happens, now we can't make it work because what did they do? They shut the schools down for a solid 18 months. So the pipeline of folks coming in weren't coming in. And the people that wanted to leave, they're now a statistic. Because if you remember when COVID first came out, who was it affecting? The baby boomers, the older generation.
Mhm.
So those folks decided instead of retiring over 10 years, let's do it over the next 3 months. So we had probably 23% of our workforce across the state in imaging alone retire and no one coming in. So now you have a big mass exodus because people are trying to travel. They're trying to make extra money because they know that everybody's short. So people are taking travelers' jobs. So that even put a more hindrance on it. So it's been rough. It's been a very, very difficult last 3 years. And I will tell you, MUSC didn't shut down. When everybody else shut down with the pandemic, we were opening up imaging centers and we were doing it the right way. We didn't have one issue with people getting COVID, but we kept our surgeries going. We kept our outpatient centers. In April,
Wow,
when
yeah.
everybody else was shut down, we were still moving. So it's been interesting, but we've had to repurpose and move people in different places.
Right. Well, that's really interesting, especially, just globally that it is, an issue. Were they, from that perspective, was the issue the same? I mean, were the reason of the issue happening the same, the challenges that they were having with staffing, or were there differences between the source of the problem?
Pretty much across the board, it was the exact same problem. I think
Wow.
the one difference that I did see between us and Ireland, which was a big difference, was the way their payer model is and the way they pay their people. It's more based off of like a Canadian setup where people all get healthcare, everybody's streamlined the same way, which made their pay a little bit lower than ours. So we have specialty care here, we have surgery centers here. Whether you want to work at I'll leave names out of it, but if you want to work at one of the best organizations in the US, you might make a little more money than if you're working in a small rural hospital. So over there, it doesn't matter. The payment model is the same. Everybody needs care. I think the toughest part was with the fee for service and the way we do healthcare here, it's still a business. And over there, it's a necessity. And people are just on waiting lists. I mean, they have 6-7 month waiting lists to get things in. So the least amount of staff they have just makes that waiting list even longer, which makes their healthcare worse. So definitely a difference in that point, but from the most point, we're in the same boat.
Right. So that makes sense. I mean, and it's crazy to think about, but it's certainly a global issue and something that was, the staffing shortage, certainly with nurses and primary care docs, was very, that problem was, in the news and of before the pandemic, and then with the pandemic coming, it just all became critical. And obviously we've been looking at technology as a way to help and sort of solve this problem for a long time. What are for you guys, what are the things that we're working to help alleviate some of these strains on the system?
So one of the coolest things, MUSC has a partnership with Siemens Healthcare, and they have a technology called Virtual Cockpit. So to me, as a child, and I'm dating myself here, but as a child, I used to watch Star Trek and things of that nature, and they'd wave a wand and everybody got taken care of, and they knew exactly what the problem was. We're almost getting to that point where that technology is here. So we have the ability to sit in Charleston and in our Columbia market, pick a hospital. I'm going to stay with Columbia since I'm the new COO there. I'm going to push that one. But we have the ability at Columbia Northeast, which is a 150 bed hospital in northeast in Columbia, one MR scanner, one tech. So they need to do advanced cardiac there. They can't do advanced cardiac because the tech doesn't know how to do the advanced cardiac. And what you don't want a tech doing, if they're going to do 3 cardiacs a month, you don't want that one person learning on 3 a month because they're never going to keep the skill set there. You had to do something over and over. It's repetition. So what we ended up doing is we partnered with Siemens to bring in Virtual Cockpit. And what that does is it allows the tech to physically sit in Charleston and remotely scan into their magnet. The tech still stays there, gets the patient on the table, and then a camera comes up, just like you and I are on right now, and virtually talks to the patient and says, this is what we're going to do. My counterpart here is going to walk you through the process. Then the patient gets down on the table. The scanner gets turned over to somebody in Charleston. In Charleston, they're physically running the scanner. They're running the sequences. They're doing the scan. And then at the end, they look at the technologist once again virtually and say, I'm done. I'm going to turn the camera back over to you. So the magnet goes back to that tech on site. They take care of the patient. They get the patient squared away and they let them go home. But this prevents that person have to come from Charleston for training or us to have to go there, or even better, the patient doesn't have to physically drive 2 hours to Charleston to get a scan that we can do a minute from their house. So we have the ability to go to any one of our 14 hospitals and pipe in with virtual cockpit. So it has helped us. We've actually normally would staff 2 MRI techs at a time. We don't have to do that. We can do tech assistance now with an MRI tech, so it's a lesser cost. So it's saved us on expenses and allowed us to give that high level of performance all across the state by sitting in Charleston.
Wow, that's amazing. And I've heard about a lot about it and a lot about sort of different integrations and uses of the virtual cockpit, but it's so interesting to hear in terms of just the that the tech is there and the over the camera that they're doing it. Now, where does the in terms of the readings and the analysis, and I mean, where is that all happening? Is that centralized? Where's the physician sitting or the radiologist sitting to do that? I mean, have you been able to reduce staffing on that side of things, or less so?
That's a great question. So the radiologists still stay in the Columbia market. So anytime you do any type of contrast, MR, CT, even in endo, you have to have a physician on standby, because if you administer contrast and that patient has a reaction, you want the doctor to be there to take care of the patient. So those reads can be done anywhere throughout the state. We do remote reads. We have people reading in Charleston and Florence. We have people in Florence reading in Charleston reads. We have specialty read docs, so our neuro docs, MSK docs, ortho docs. So they all have different type of specialties, and they can be pumped to those docs. But there's always a physician standing by in the department. But our cardiac reads are done in Charleston with our cardiac specialist.
Right. And so it sounds, I mean, that's incredibly powerful in terms of the tech and being able to reach those markets. What are some of the shortcomings? Like, are there things that you wish it did better, or are there areas that you're continuing to work on and to improve?
So I will tell you, I think one of the biggest things that you don't think about when you're doing things is the budget per se. So, we built this in, we did everything. We're going to do all these different types of studies, neuro, MSK, but there's different types of software. So in cardiology, you need a certain set of software parameters to be able to read cardiac. We also need the setup so that you can manipulate the data, I guess is the best way to say that, so that you can actually transition to heart in different sequences. And we have found, well, we want to do cardiac in that market, but we don't have the proper software on the magnet. So we have to upgrade that software. That's been our downside. We built in, because it's new, I think we're the first people, maybe the second person on the East Coast that does virtual cockpit. I think it's done up, I don't want to quote anybody, but it's done up north. But I will say that when it's new, you kind of have to go through the bumps and the bruises of things that you didn't think of. And we didn't think about, hey, we need cardiac software for each one of those magnets. And that's not cheap. It can be anywhere from, $40,000 to $200,000. Now the offset of it's fine. And in the long run, you're going to need it anyways. But it's just, when you don't budget for it, there's nothing worse than going back to the CFO and saying, hey, we forgot something, right? So no leader wants to tell the CFO that. You can only do that.
Especially not now.
No. So yeah, I would say that's been our biggest downside with it. But for the most part, it's been pretty exciting. It's really cool technology.
That's great. I mean, I know, personally, I live in Hermosa Beach. So LA is far. Anything in LA is far, right? So when we have to get our imaging done, it's always an hour to 2 to get there and get back. So it's a long to save that for the patients is a real experience improvement. So that's great. But you talked a little bit about the staffing, and obviously that's solving it a bit. But when it comes to kind of that clinician pipeline and what you guys are doing to kind of get ahead of that, now that the pandemic is not quite over, but it's we're moving past it. What are some of the things that you guys have done to kind of build that pipeline back up?
Honestly, the pipeline never went away. It actually, I want to say it built up. So we've had, like in that market, the cardiacs, we had probably a month and a half worth of cardiacs that we really needed to do. So it's really just ramping up extra time on weekends and evenings where we can focus just on cardiac, because cardiac scans take a little bit longer. Not to get nerdy, but if we did a abdomen MRI, it's quick. But if you do a full cardiac, it could be a little bit longer of a sequence. And it's not something you want to rush, right? There's movement, so you want to make sure you get what you need done. So we really had to build out almost like an OR. We've had to build out block times and just load those up. And then make sure we have the tech sitting in Charleston and make sure we have the tech sitting there, maybe a nurse, depending on what studies we're doing. So it's really being efficient with your time has really been what we've had to do, because truly the volume's always been there, right? Like when COVID happened, I think that was the biggest thing. I don't know who said it, but it was somebody across, if it was one of the politicians or the physicians nationally that said, just because there's a pandemic here, people are still sick. Like that didn't go anywhere. And honestly, in my mind, and really a lot of the physicians' mind, it just got worse because people prevented themselves from coming into the hospital. So a minor heart issue is now turned into a major heart issue. Right. And probably for the next 2 to 3 years, we're going to be playing catch up with all these major diseases that people just ignored. But you know, that's where the pipeline is. The pipeline's there. Right. Really just making sure we have the bodies and staff to do the work and quality work.
Right. So to that though, in terms of the clinicians and the techs and getting them, you know, into, you know, hiring and staffing, what are some of the things that you've done?
I would say that we have gotten very creative. So in the past, I think 26 years of doing this now, 10, 15 years ago, the local schools, community colleges, tech schools would call you to send their students in. And, you know, you'd fight it a little bit like, gosh, we don't need any more students. We already got one here. Now we're all fighting over the relationships with the schools because there's a huge shortage. Just to give you an example, X-ray programs and ultrasound programs, they may start with 24 people in their program because they don't want to get it so big to start with 50, 60 people because you can't teach that much healthcare to somebody. So they'll start with 24 to 30 people. They usually only graduate about 12 to 16 because of the washout rate. People realize how hard it is and it's a lot of work. It's really a 4-year degree condensed into 2 years. So they're just cramming a lot of material. And if they don't have the manpower, the bandwidth to take care of that, they just usually wash out and then they end up with half a class. So what we've done to be strategic, we've done a few things. We have relationships with 12 schools throughout the state of South Carolina. We all sit on different boards. So I sit on 2 college boards here in Charleston. And then my regional director of Columbia sits on a board there. My director of radiology in Florence sits on 2 boards up in that market. So we all sit on different boards to create relationships with the colleges. But where we really got creative is, I don't think he'll mind me bringing him up. His name is Eric Mack, and he works for me. He's also just stepped down, but he's for the last decade or so been the Charleston School Board president. And he helped us on his way out of retiring from the school board president. He helped us create a relationship all the way down to the high schools. So what we've done is we budgeted FTEs, with full-time employee, into our budget. And then that money goes back to the city of Charleston, into the high schools, to act as funding and scholarships back into the high schools. The high schools have partnered with the colleges, and the colleges are partnering with the high school and the university. So what we're doing is it's 3 people all bringing in one relationship, and we're doing it in underserved areas where they might not be able to afford going to college. The per income of the family is very low. So college is probably, unless they get straight A's and get scholarships, they're not going to get these opportunities. And we allow the school board to go ahead and put in kind of like a dream essay. I want to be in healthcare, and we go recruit, and then they put in for it, and then we pay for their college education, and then they're guaranteed jobs with us at the Medical University of South Carolina. So we've actually started from just taking all the college students. We've realized there's a competitor in this market, and we had 19 vacancies. We have 732 employees just in imaging alone. So we had 19 vacancies, and the people across the street had 5 vacancies. They're a lot smaller organization, but there was only 16 graduating in a class. So even if we hired all of them, we still didn't have enough to fill both of our jobs. So we decided we got to get creative. So that's why we've gone down to the high school level. And now we've built kind of like a full, as you would call, pipeline for the next decade or so, because they're going to be taking them all the way from high school up.
Yeah, that's amazing. That's great. And I think, as we talk about some of these problems, and we often talk about the technology solutions, but this is a community solution, it's a partnership solution, and it really gets at the heart of, what the system really needs. And it also, it sounds like there's a effort to create equity and connection with the community. So there's a, sort of branding and relationship there. So that's great. I'm curious just because, I wanted to be a doctor too, and I got into it and working in a hospital and thought, no, I'll go into events. But right now, even, I've got kids, and the idea, what's the interest level? Is there excitement there, at the high school and college level, or are they like, no way, I'm going to be an influencer?
Yeah, I have a child that tells me he's gonna be an influencer. Anyways, I will tell you that it's not the way it used to be. So I'm dating myself, but when I first came into healthcare, it was very, I'm gonna just be blunt, it was very super sexy. Like there was money involved in it. You were saving lives. I mean, they had ER shows on it. There was even funny shows like Scrubs. There was all these different shows based on healthcare. And a lot of people wanted to get in healthcare. It paid very well. When I first started, if I needed something, I remember I was a very low level manager and I said, gosh, I need this new piece of equipment. And it was $50,000. Now, just keep in mind, 20 years ago, $50,000 would probably be closer to 100 now, 90 to $100,000. And my boss was like, all right, go ahead, buy it. And like literally wrote a check that day for almost $100,000 piece of equipment. Now it's like, if I need to buy a stapler, they're like, well, have we priced out the best stapler? And it's really to that point. So Medicaid and Medicare reimbursements were very lofty 20, 30 years ago, even 15 years ago. And things got tighter probably around, Obamacare 2008, 2010. In Medicaid, Medicare rates dropped almost 40, 50%. So which means the revenue coming into the hospital dropped that much. Physicians used to make millions of dollars a year, and now there's a lot of physicians that make less than directors of radiology. They don't make the money that they used to make. It's really not moving in the same direction, which means let's think about it from these young folks. Do I want to be an influencer and make a lot of money sitting here in front of my computer talking about a product, or do I want to go into an area where we've got COVID, we've got blood, I've got to change bedpans? It's gone from super sexy to super scary. And I think a lot of folks are straying away from that. It's a lot harder to recruit now. You really have to work pretty hard. Now, if you go to the community colleges where they're already into the program, you're committing something different. Like you're committing culture, family, which is what MUSC is all about. Creating a family and a culture where you can go to work, you feel like you're at home. But when you go to the schools, you got to make it, you're changing lives, you're saving lives. So you really do have to change the way you talk to them about recruitment. So yeah, for sure.
Yeah.
I don't think it's the same as when we were younger. Yeah, it's definitely not.
For sure. I love Scrubs.
Yeah, that was a good show.
It was a good show. But we had really good healthcare shows back then. But yeah, it has changed. And I think, and I always say this, and this is where because I get frustrated with healthcare a lot and the slowness of change, but, even from the, whether you're in pharma or the payer side or government or policy, people that get into healthcare get into it because they do, they do want to save lives, and they do want to change the way people are cared for and improve that. So it all comes from a good place and good people. So there is a good selling point. It still has that to it. So but to that, we always like, health impact. That's our thing, is making an impact. So we always like to ask our folks, what is that one big problem? If you could fix one big thing in healthcare, what would it be? If you had the wish, the X Prize, the Star Trek
magic wand. I would say stability. I think I already mentioned we have staffing issues, right? So a lot of the things that we're getting now is multiple generations where they see that if they, when I was younger, it was if you were loyal, that was a good thing. You spent 8 to 10 years in organization. When you were looking at somebody's resume or CV, you were like, this is the person I want. And now, not so much. You're looking at the 3 to 5 year window. Now, if somebody goes somewhere every 16 months, that's when you start to get nervous. But a prime example is me. I've been here for 3 years, and now they said, okay, we want you to go to another role. Now I'm staying with the same company, but once again, it's a different role. And I think there is just like any sports team, right? Like I'm a huge Carolina Panthers fan, and they have zero structure with their coach. Their coach has been a revolving door. The quarterback's been a revolving door. So the only way to really grow a program is to have structure. And we don't have that in healthcare anymore. People are going in the organization, staying a year or 2 years, and then they go across the street for $3 more an hour. And then guess what? 2 years later, they come back to that organization because now that organization's paying $3 an hour. And we just need some stability across our globe, really, and what we pay our folks, what they're getting out of it. So people stay at an organization because of the organization, not because of the dollar. So I would say, if I had a magic wand, I wish we could just have a little more stability in our workplace.
That's great. I like that. And I think, I know I was, with New Year's coming in resolutions, I was just reading someone who was saying, what's your word of the year, and stability is a good one because there has, certainly over the last 2 years, the instability has been a lot. And just, as we do kind of going through and trying to bring people together, and you see how much people have moved, and whether they've moved across the street or across the country, people really are moving a lot. And that does impact the stability of an organization and the strength of it, because that's what it comes down to. So that's great. I like that. And I like it as sort of a theme to think of and to end on. But thank you so much for being here. It's so good to see you. And I'm excited for your vacation that's coming up, but I hope that we'll be able to see you in person soon.
Yeah,
at one of our events. Great. Well, thanks so much, Ron. Take care. And thank you everyone for listening.